bear in mind the recording. And as if by magic, the recording has started. Okay, so hopefully everyone's seen the agenda. What you're going to get, unfortunately, you're going to get a kind of PowerPoint presentation from me, but hopefully what that's going to do is clarify, what this program is that we're talking about, developing community services for self-harm, talking a little bit also about our role and the evidence. We'll then hear from Jess in West Yorkshire and Holly from North East and North Cumbria about what some of the things that might be going on, and we're very conscious that people are at different stages of their kind of development, self-harm. So it's very conscious of that. It's very informal, and we'll save kind of questions, if you like, for a discussion session towards the end of the morning. Hopefully, if I manage to keep everyone to time, we'll have a quick comfort break in about an hour. So I hope that's going to work. So we've got a couple of hours really. I expect we'll probably fill most of that based on kind of past experience, but we'll get cracking if that's okay with you. Why? Okay. So Gwen, are we?
Yeah, it says it's recording, so.
Okay, that's great. Fine. Sorry, I'm just looking at the chat here. So Keir. Yeah, that's fine. Okay. That's great. Thanks, Keir. That's great. I'll bear that in mind when I'm directing the agenda. So we're going to start. I'll start with a presentation, hopefully kind of orientating everyone. So let's get the screen up. Debbie, you're the person I can see on the screen today, so hopefully you can see that and hear me if you nod. Yep, brilliant. Okay. So self-harm, we're aiming to improve community services for self-harm. This is what I'll kind of talk about over the next kind of 40 or 50 minutes. So I'll start with a bit of context, why self-harm is important, the extent of the problem. That's going to be familiar to all of you, I guess. I'll then move on to what the actual current NHS England kind of programme is about and what we're all doing here. I'll move on to thinking about, because when we develop our service offer or develop our services for self-harm, thinking about the different settings where we might want to focus our efforts and saying a little bit about those. Some settings which I think are probably quite well covered by current provision, other settings which are perhaps less well covered. I'll then move on to some of the evidence, just a quick whiz through some of the evidence about what works and what perhaps works less well for self-harm. And then, because everyone keeps asking us about it, just a little bit about self-harm and COVID-19. So I hope that's okay. We'll make the slides available afterwards, as well as obviously the recording available for you to share. Let's start with a bit of context. Now, I'd like to start with a little bit of historical context, because I've been working in self-harm and been interested in self-harm for almost 3 decades, so about 25 years. And one of the things that often comes up is, how things developed over that time. And last year, it was quite a nice kind of, if you like, editorial exchange, so kind of discussion in print between this is the guy, Alan House, Professor of Psychiatry in Leeds, who kind of trained me. So when I came into research 25 years ago, he was my boss. And he published an editorial saying, well, things have really not improved at all. I countered actually by saying I think things have, we've made significant strides in self-harm service provision, I think, in the time that I've been in the area. But actually, there's still a long way to go. And that's, if you like, where we come in. I think we have made great progress. People are getting a better deal, but still we could do a whole lot better and develop our services. And why I think this is particularly exciting, this programme, it's a real opportunity for us to improve things improve things for service users, for patients who have self-harmed. And, you know, there's a lot of interest, a lot of kind of policy priority at the moment, lots of kind of documents, policy documents, guidance coming out. You know, it's a real priority and a real opportunity to improve things. Now, self-harm, we tend to use the inclusive definition and a kind of nice definition when we're talking about self-harm. So self-poisoning, self-poisoning is the most common method in hospital settings. Self-injury, so self-cutting, is more common in community settings. But we have this kind of, you know, catch-all. So it's irrespective of apparent motivation or medical seriousness. So in general, when we're talking about self-harm, we're not trying to separate out attempted suicide or non-suicidal self-injury. We're treating it as a whole. That's not to say that everyone needs the same treatment. Of course, treatment needs to be individualized, but it's a recognition that even people who are labeled as non-suicidal have a greater risk of suicide and adverse outcomes. And often, you know, it's not easy to kind of separate out exactly what someone's motivation or intent is. So we've got this inclusive definition, really, so people aren't, if you like, filtered out of treatment. But self-harm is really common. So just in terms of hospital presentations, over 200,000 episodes in England, 150,000 people. So one of the commonest reasons for hospital presentations. One of the things that often comes up is, you know, when you talk about self-harm, people think, oh, self-harm, that's a problem with young people, isn't it? And I think one of the really important messages is it occurs across the lifespan, so middle-aged men, middle-aged, women in middle age, in older adults as well. This was a paper we published a couple of years ago looking at older people in primary care who had self-harmed. And I think that's an important message in itself. Older people self-harm too, but for older people, I think the risk of suicide, older people who self-harm are at greatly increased risk of suicide. Everyone who self-harms is at increased risk. So in the year after someone presents to hospital of any age, they're at between 30 to 50 times higher risk of dying by suicide. But for older adults, that's even more marked. And in this study, you know, only about 1 in 10 people were referred to mental health services. So group who are at high risk, not really being referred to statutory services. But of course, you know, the different groups may be having different targets for intervention. So for older adults, you know, social isolation, bereavement, physical illness, and psychiatric, psychological disorder might be potential targets for intervention. But the important messages there are occurs across the lifespan, and of course the link, the association with suicide. So common problem, potentially serious consequences. How do we do in terms of current management? I think this Samaritans report from last year summarised things really quite well. It was called Pushed from Pillar to Post, and I think, you know, it summarises rather well the experience of some service users, some patients, where, you know, they've hurt themselves, they've self-harmed, they're trying to get help, but they're actually kind of going from one service to another, from primary care to community mental health, trying to get referred into talking therapies, not being accepted or being accepted, and this idea of kind of fragmented services. So this, the current programme, that's what it's all about. It's to kind of try and address that fragmentation, trying to improve the care people get after self-harm. So the current programme, so there's been, I think, some discussion about, you know, where does this all sit now? Where does this current programme, the self-harm bit of work, actually sit? So it's actually within, you know, the long-term plan and within the community mental health framework. So as part of the kind of transformation of community mental health services, you know, NHS England Improvement have put in lots of money. So it's about £1 billion. And really the essence of that, many of you have been very much involved in that transformation. The essence of that really is, I suppose, integration between primary and community mental health care. And the idea is, you know, a seamless service. So someone pitches up and they have a seamless service with different aspects of care kind of co-located. And they might be co-located physically, they might be co-located virtually, but the whole thing is about integration and avoiding, you know, if you like, barriers to referral and accessing treatment. So that's a major part of the investment. Now, people have said, well, what's the money that's specifically allocated to self-harm? And you know, the message from NHS England, the message from us really is, if you like, there's no additional funding for this work. It's really part of the community transformation work. So many of you are kind of community transformation leads or involved in that process, and really this is part of that. And the ask here from NHS England and ourselves is really thinking about how you develop a plan to improve community services for self-harm, and then kind of obviously implementing that. So really kind of exciting time from our point of view. So what are we doing in all of this? NHS England have asked us to help support all areas with evidence. So we're the experts on evidence. We know about the latest research. We're responsible for producing some of the research. So we're going to support you with that. We can help you with what's evidence-based and what isn't. We can comment on your plans, you know, as you develop them. In the first wave of this program, so this is the, if you like, the second wave, we you know, got comments to the plans and formally commented on them. This time, you know, we're happy to help you develop them. There's no requirement for us to kind of give you 2 rounds of feedback, so we won't be doing that, but very happy to advise on those. We'll talk about, yeah, happy to talk to you about how you implement things, how you measure stuff. I'll come on to measurement in a second. So we'll do that by having site visits. In the olden days, as I said, those would be face-to-face. They're virtual now. This is one of them. So we'll hear from you, you'll hear from us, and we'll you know, hopefully that will help in developing your thinking about what you do about self-harm. You'll get regular email contact from Debbie and the team, just checking in with you. Caroline and Leah, every month, every 6 weeks, will run clinics. So that's open to everyone, where people might bring issues, they might bring kind of dilemmas, and kind of we'll think about those together in a kind of interactive setting. One of the key things here is shared learning. So we had 12 early implementer sites that have been at this for a while. Some of them have developed really good plans for self-harm, but actually, you know, about 30 sites in this second wave, and a lot of this is about shared learning. So thinking about what other sites are doing, pinching from each other, stealing ideas in this context is really good. Colleagues at the National Collaborating Centre for Mental Health always kind of make that point, that this is about shared learning. And there's a website as well. So the website is here. All these slides will have links on them, so you'll be able to kind of click on them, and hopefully that will take you through to the link. So here's our website, and we've got kind of this continuously updated, so various things. So, you know, if you want to know about kind of guidance, if you want to know about risk assessment scales, you can click on those, and that will take you through to some of our research. So this is continuously updated, so do take a look at it. If there's stuff missing, if there's stuff wrong, if there's stuff, you know, you can think that might be helpful to people, do let us know. Ian is our lead on that, and we can incorporate that. So that's a live resource, the website, which I think is really good. So key things for you to think about as you're developing a plan. One of course is implementation. So how are you going to implement? And you need a methodology, I think, to implement. You know, sometimes in services we just kind of implement things without thinking about how we're implementing them. But you know, implementation methodologies like quality improvement and other methodologies, I think, are really helpful if we're thinking about, you know, how we formally introduce things. But the other thing, of course, is measuring. So making sure whatever it is we're up to has some kind of is doing some kind of good. Obviously, there, you know, we're talking about self-harm here. So one of the crucial things will be data on self-harm. So, you know, outcome measures. You might be thinking about hospital presentations. You might be thinking about admissions. You might be thinking about, you know, the community incidents. Obviously, those are important measures. They're actually quite difficult. So Caroline's been spending many years with our local self-harm monitoring project, and will tell you how difficult some of these things are to codes. You know, sometimes self-harm isn't well recorded, isn't well kind of delineated in databases. So this is absolutely, we'd like you to record self-harm, but it is quite a challenge thinking about how you record self-harm. But the other thing are, you know, if you like, process type measures. So it's not just about outcome measures, it's process measures. So, you know, thinking about to what extent your local service, your local area implements guidelines, implements quality standards. Thinking about, you know, getting feedback from direct feedback from service users after they've used the services, or activity levels. Also, you know, important outcome measures, important in terms of measuring what you do. So measuring is really important. So some of you might be a little bit daunted at this point, thinking, wow, we've got to develop our self-harm services. Goodness me, you know, how are we going to do that? I mean, of course, you're not starting from scratch. There's loads of brilliant work going on in areas already, and we heard from some of them recently. So we've been doing a few of these meetings. So, you know, there's lots of activity going on, and there'll be lots of activity going on in your areas too. And the other thing is, obviously, you're the second wave, so you can learn from some of the earlier implemented sites. So on the website there, what we've tended to do is turn some of the early implemented sites plans into these infographics, which people seem to like. So this one's from Frimley. Their one was about, you know, brief psychological intervention after self-harm, so timely access, you know, 4-session intervention, and also thinking about how they'll measure impact. Here's the one from Somerset. This was about developing digital resources, which I know a lot of areas are doing, and again, thinking about how they're going to measure impact. So one thing to kind of reassure you is, yeah, you're the second wave. The early implementer sites have been at this. There's some of the summaries of their work on the website, and you can learn from them. But this work, the self-harm community services work, also sits in the context of other work. And again, it's about linking with other people in your areas, in your organisation. So this is a sequence. So a sequence, for those of you who aren't familiar with them, is a like, if you like, a health service kind of target, which comes with a little bit of extra funding. So services are encouraged to kind of meet the targets, and they get a little bit of extra funding. And we've been trying to get one around self-harm for many years, and I'm really delighted to say that from April of this year, there will be a sequence on self-harm, and really that's aimed at improving the psychosocial assessments after self-harm, improving the proportion of people who get an assessment, improving the quality of those assessments. So the sequence is going to be out there. So a lot of you may be involved in discussions locally around how services are going to meet that sequence. If you're not, though, I think one of the messages from today's talk is link with those people, because although the sequence really about hospital services, if you like, it's the mirror image of the community self-harm programme. Again, one of the other bits of existing work that's going on that some of you are directly involved in, but some of you may need to make contacts with the people locally who are leading this work, is the Quality Improvement for Suicide Prevention programme, also funded by NHS England, where basically now all countries have been covered in different kind of waves over the last 4 years. And again, what we're doing is we're helping people to think about how they implement evidence-based suicide prevention in 3 areas. So it's mental health patients, people who self-harm, and men in midlife, particularly in primary care. So many of you involved in that programme. Those of you on, you know, would link with your suicide prevention programme Leeds, because actually one of the priority areas is self-harm, and there's lots of great work going on around assessment, around interventions, around psychology input into emergency departments. So linking in locally and with the QI programmes more widely, I think could really help. So linking in with sequencing, linking in with suicide prevention programme Leeds. The other overarching, I think one of the overarching kind of elements of the programme, and something we'd strongly encourage, is just making sure that you've got adequate service user, patient and carer involvement in any plans that you make. I think a few of you were at the kick-off event for this program that we had towards the end of last year, and you know, that comes across. So Dr. M was the service user contributor at that, and you know, when you hear from someone that's experienced services, been through it, that has so much impact. They've got so much kind of insight to offer, and it has a real I think benefit in terms of kind of service development when you're asking, you know, in the old world about commissioners, but you know, in the new world about, you know, who's making the decision about services. If we can get, you know, service users there as part of the development process, I think that's so helpful, and there's evidence that it improves outcomes too. Okay, so I've talked a little bit about the general context and the current program, so hopefully everyone's a little bit clearer about where this piece of work sits. I want to move on now to settings. So many of you will have seen me present this before. This is the Iceberg model of suicidal behaviour. So, you know, this idea that suicide is, you know, if you like, at the top of the iceberg and most serious consequence, but under that, you've got self-harm, which presents to maybe hospital services, but then under the waterline, almost kind of hidden, is this bigger iceberg, if you like, the iceberg below the water of self-harm in the community. And I think one of the ideas behind this program, one of the things you need to be thinking about is how, you know, you provide something at each level of the iceberg. So, you know, people under community mental health services who maybe aren't getting access to psychological interventions, people who present in crisis but might just be sent home from an emergency department without any follow-up, but then also people who are presenting to their general practitioners, or people who don't come to the attention of services. So thinking about what the offer might be in each of these areas, and obviously making sure that you know, different groups are covered. So young people, older adults, we've already talked about, people from LGBTQ plus communities, but also people from ethnic minority groups, and making sure, you know, you've got coverage, and different areas have, you know, different makeup of catchment populations, etc. But yeah, that's important. So this is some work we did specifically focused on ethnicity and self-harm to young people in Manchester. This is work led by my colleague Bushra Farouk. And the big story really is, I mean, young people from ethnic minority groups tended to live in more deprived areas compared with their white counterparts. But the big thing was access to treatment. So everyone should get a proper assessment after self-harm. But in this study, we found that young people from ethnic minorities were less likely to get a psychosocial assessment than white young people, and less likely to get mental health aftercare. So this access to treatment, I think, is really important, and something you need to bear in mind when you're developing your plans. So for me, one of the big kind of opportunities here is thinking about self-harm in primary care, because I think traditionally that's a setting, an area that's been quite kind of neglected. And because this is about, if you like, community, this is about community self-harm, self-harm that occurs in the community, I think self-harm is a key area that we can intervene. So this is a study led by my colleague Matthew Carr, big primary care database, and looks at self-harm by deprivation. What we see here is people split in order of how deprived the areas are they live in, how socioeconomically deprived. And what we see is people who live in the most deprived areas, the fifth most deprived areas, have the highest incidence of self-harm. So we know that. We know deprivation is associated with mental health, ill health, it's associated with suicide, it's associated with self-harm. So that's perhaps not surprising. So a greater burden of self-harm in deprived areas. But what's quite interesting is when you look at then access to kind of aftercare and referrals to mental health services, these are referrals to mental health services. And what you see is, although people who live in the most deprived areas have the greatest incidence of suicide, they're the least likely to be referred for mental health mental health follow-up, mental health aftercare, and I know public health colleagues, some public health colleagues are on the call. A kind of good example of the inverse care law, where basically people at the most need are getting the least access to care. So the inverse care law. So that's something really to kind of think about. In this big study, I mean, there were other things as well. Quite a lot of people receiving medication, not very many people perhaps being referred to mental health services. So thinking about the balance between medication and referral in primary care, especially for self-harm, and thinking about inequity and access. What can we do about self-harm in general practice? There's not a whole lot of research here. This was a systematic review done by our colleague Faraz Mughal, as academic GP working at Keele. Thinking about some of the things where we might help, we might improve the management of self-harm. Obviously, training comes up, service provision, clinical guidelines involving people, but also some of the barriers which will be very familiar to many of you. Service provision, not having the services to refer into, thinking about kind of assessments, local factors, referral thresholds, that kind of thing. So very familiar. Encourage you to click on the link and take a look at that, because I think general practice, primary care, big opportunity for thinking about what we do and how we might improve. Other areas that are really important, of course, are educational settings. So this program itself is if you like, 18 plus. So the self-harm community services is 18 plus. You'll have other work going on locally in relation to younger people self-harm, and we'd encourage you all to kind of join it up. For some areas, of course, universities, many areas have universities in their catchment. It's a hot topic, self-harm, suicide prevention within university areas, and there are existing resources out there. But again, thinking about working with educational settings to how we might best help people who self-harm. And it's not, of course, just about statutory services. It's about the third sector voluntary services. Of course, we're familiar with many of them as providing information, etc. But perhaps the two best known third sector providers in this area, Harmless and the Samaritans, and actually being actively involved in service provision. So we heard from colleagues in Nottingham yesterday about Harmless's work with direct service provision to support mental health services, to support statutory services, and Samaritans as well in many areas of the country, and locally in the Northwest. Samaritans very happy to help us with providing some follow-up for people who haven't had an assessment or left before being seen. So really important that you involve third sector colleagues as well. And of course, the other setting that's really, really important for self-harm is the home setting. So thinking about involving families, how we best involve families, I think is really important. So some resources there. One of the things that often comes up though is the whole issue of confidentiality, and not being able to share information. I mean, this is there was confidentiality. There's a consensus statement on confidentiality published a few years ago, and it's recently been updated. This is the Zero Suicide Alliance, if you like, kind of further guidance and kind of implementation guide. And the idea here is services mustn't, if you like, have a default position of kind of confidentiality or hiding behind confidentiality, because we know sharing information, obviously with service users, full consent, can help outcomes. So this is about how we change the default position when a service user comes into service. Say, well, we know involving families, we know involving significant others will improve the care that areas are able to provide, so we want to involve them. Is that okay with you? Obviously there will be instances where that might be unhelpful, the person might not agree, and we will, that needs to be respected. But information sharing can also be very helpful. So please do look at that guidance. Okay, so we've talked a little bit about the different settings, making sure that you have coverage of perhaps underrepresented groups. So let's move on now to the evidence. And in some senses, we've got a bit of a kind of head start with the evidence in self-harm, in that we've got NICE guidelines. So I've been involved in NICE guidelines for a very long time, and it's always striking that the first NICE guideline self-harm was 2004. Previous guidelines even older than that. I remember guidance from kind of the 1980s as well. But there's been, the guidance in 2004, the updated the longer-term management guidance in 2011, the quality standards in 2013, which in some senses are a kind of summary of the most important bits of the guidance. And of course, many of you all know that we're currently updating the self-harm guidance into one. So these two are going to be kind of amalgamated. Yeah, you can still comment, so register as a stakeholder and comment. The consultation period ends on the 1st of March, so encourage you strongly to contribute to that guideline. But the guidelines, if you like, summarise the evidence, so they're a really good starting point when we're thinking about what we might want to do in individual areas. The other thing that comes up again and again is evidence-based training. What training has the best evidence base? There isn't a huge amount of, if you like, outcome data on the outcomes of good quality training versus not. But we did some work along with Health Education England 2 or 3 years ago now, thinking about what the key competencies might be for staff. Working with adults and older adults, there's another competence framework for kids. There's another competence framework for non-specialist and kind of, if you like, public health type settings. And what this does really is summarise the key skills, knowledge, and attitudes that we might expect staff to have. So basically, if you click on the link, you end up with a kind of map. You click on different bits of the map, and it comes up with a list of, if you like, key skills, key attitudes and bits of knowledge that we would expect staff to have. So basically, I know a lot of areas have developed their own training. Other areas are kind of commissioning external training. And our message really is, one of the things is you can use the competence frameworks to almost audit the training, look at gaps, look at things that you might want to kind of develop as aspects of your training. And there are a lot of kind of, training resources out there as well. But many of you are familiar with the competence frameworks, but do take a look at those. So you've got the guidelines, you've got the competence frameworks. What about kind of, if you like, the research evidence and what that tells you? One of the things I think that's really important is making sure that if someone's hurt themselves, they get an assessment. So certainly if they're presented to services, obviously it's very difficult if they're in the community and no one knows about the self-harm. But for those people who present to services, they deserve a proper assessment. And I suppose the thing that's still surprising to me is around half the time still, someone will present to services with self-harm and they won't get assessed. So we could really do something there to improve the levels of assessment, because just that assessment, research suggests, can reduce the risk of repeat self-harm by 40%. How does it do that? So this is some really nice qualitative work from Liam Quinlan, who's on the team but unfortunately can't be here today. Just thinking about what service users said helped, and this is perhaps what we'd expect. Humanising care, something that's collaborative, space and time to talk, compassion and reassurance. So it's something there about the quality of the interaction, the listening there and then, but it's also about plugging people into aftercare, so people receiving help after they've had this proper assessment. So thinking about how we improve assessment. But the other thing that's really important is what happens afterwards. So what happens after the assessment? And one of the things we know is that talking treatments are an important part of aftercare. There's a nice busy slide, but all I want you to look at is that black diamond there. This is a forest plot, so it just summarises lots of different research, lots of different trials that have looked at people who self-harmed have received a psychological therapy. And the bottom line is, if you get a talking treatment after self-harm, you're between 30 and 40% less likely to repeat. So providing some kind of aftercare, we know very few areas in the country provide routine aftercare through psychological intervention for self-harm. But if we can do that, we can reduce repeat rates. One of the things I'm always asked is, well, okay, what talking treatment should we provide? Here's a meta-analysis by some of my colleagues in Australia. basically they looked at this and they didn't see any great differences by type, intensity, or whether the therapy was delivered at home or in the hospital. Obviously, there's issues of access if you're delivering people therapy at home. Also, now, of course, online and remote consultations as well. So the message from, anyway, this study is, the exact flavour of therapy doesn't matter. As long as you're providing some kind of evidence-based treatment in terms of a talking treatment, that's probably a really good idea. But if you're going to provide it, I think you need to provide it very quickly. Why am I saying that? This is some data looking at how quickly people repeat after self-harm. So these are people who've repeated within a year of self-harm. And basically the message is that if people are going to repeat, they tend to repeat quickly. So in terms of the first 30 days, in first month, a third of people who are going to repeat within a year repeat within the first month. And it's even more stark than that, because 10% of people, 1 in 10 people who are going to repeat, will repeat within the first 5 days. So this idea that, we're going to send them an outpatient appointment in 3 weeks' time, or we'll refer them for, some kind of self-help that's going to start in a month, we're kind of wasting our time. If we're going to provide aftercare, if we're going to intervene, we need to do it quickly, and obviously that's a challenge. So if we're going to get in there, let's get in there quickly. Risk is something that those of you who work directly in mental health services know that all mental health services are obsessed with risk. In a lot of areas, risk tools and risk scales are still in use. After self-harm, to score people. What's the research evidence from there? Research evidence from ourselves and others. Some of the papers there behind the box. The positive predictive value is about 5%. What does that mean? That means is if I rate 100 people as at high risk, actually 5 of them will be at high risk. So 5 out of 100. In other words, I'm wrong 95% of the time. But that isn't the biggest problem with risk scales and the whole approach to risk assessment. It's all the people we rate as at low risk, because they're quite a large group, people being rated as at low risk on scales or other things. All the people who die, all the people who repeat self-harm in that low risk group get excluded. So that's the problem. If you're using risk scores to allocate treatment, you miss people and you exclude people. So we suggest not using risk tools and scales. Risk assessment isn't a checklist, and risk itself kind of isn't a score. What about the role of digital interventions? Obviously in the last 2 years we've all become much more familiar with these. It's interesting because researchers, even when they look at the same evidence base, come up with different conclusions. So this is looking at digital interventions for suicidal ideation and self-harm, and this group of researchers said, well, we need further research. This group of researchers from Sydney said, well, no, actually they're ready to be implemented and disseminated. What's our view? Our view is, I think there have been times over the last 2 years where we've had no choice, where we've had to provide interventions and assessment remotely. I think for our view would be, there is some evidence base behind this, not just from suicide prevention, but from depression and other things. And hopefully going forward, what we'll be able to do is provide a choice. So for some people, it definitely wasn't for them, and I can just think of assessments that I've kind of seen over the years where the finer points, the finer kind of clinical details, you wouldn't be able to pick up over Zoom or Teams. You needed to be in the room. So I think definitely a role for face-to-face. But other people have told us, well, actually, it's been a lot easier to get to appointments. It's been a lot easier to attend. I've really liked it. It means that I haven't got to kind of deal with trying to find parking in the hospital. It means that I can just get in and see my therapist, and so choice, I think, going forward. But digital interventions, there is an evidence base and they can be helpful. Okay, what I'll do just in the last few minutes then is talk about the last 2 years and what's happened with self-harm and what we might do going forward. This, of course, is what we're all, I mean, it's difficult to remember back, isn't it, to the spring of April 2020. It's all been a bit of a blur, but remember what it was like right at the beginning. Everyone was worried that the indirect consequences of COVID-19 might be even greater than the direct consequences. And what do we know about the impact? I mean, even fairly early on, I think we knew that it was having an impact on mental health. So this is a study from some colleagues in Manchester, and it's a repeated kind of survey, if you like. So looking at quite a large number of people, thousands of people, where they're looking at mental distress on a questionnaire. So it is self-report on a validated questionnaire, and basically during the early part of the pandemic, about a 10% increase in clinically significant mental distress in the population. How did that translate into self-harm? Well, it was interesting. So this is data from primary care. This is a graph from primary care, work led by my colleagues Sarah Steig and Matthew Carr. And we kind of summarised some of the findings kind of early on. And what we saw was a big fall off in help seeking for self-harm in the early part of the pandemic, from primary care, from secondary care. Of course, what I'm not saying is that might be a genuine reduction in self-harm incidents, although it's plausible it might be, because we know that suicide rates in many countries, including England, reduced in the early part of the pandemic. So contrary to expectations, they went down rather than increased, but self-harm presentations also decreased. What's that down to? It's probably more likely down to, remember those messages to kind of protect the NHS, people being also kind of frightened to seek healthcare back then, and also accessibility of services. So primary care being less accessible, mental health services being less accessible. But this fall off in care, I think, has been echoed to an extent in future work. And it isn't just the UK, so this is data from France, all of France, looking at hospital admissions now for self-harm. And basically what this is showing is for most age groups, the number of admissions fell in 2020 versus 2019. But there were exceptions. So for older adults, actually, in this study, the admissions for self-harm went up. And as in services here, I'm sure many of you, very familiar with this, that we did have fewer presentations, but for people who did present, there was greater acuity. So for self-harm, more a greater proportion with kind of violent methods, more ITU admissions of death. So the acuity of those people who did present was higher, perhaps people presenting later. So if you like, help seeking for self-harm reduced in the early part of the pandemic. What about community self-harm? So this is the great study from UCL, from the social survey that they're doing. Tens of thousands of people participate in this, a repeated kind of survey, if you like. And actually, they've not got pre-pandemic data, but during the pandemic, self-harm, reported self-harms remain fairly static, actually. This is a reminder, of course, so that in this graph it's split between those with a mental health diagnosis and no diagnosis, and people with a mental health diagnosis suffer more, have more self-harm than people without. So it's an important reminder there, but no actual changes in incidence. So a reduction in help seeking from mental health services from primary care, no reduction in reported self-harm in the community. The question is, where are people going? This is one study, not UK data. It's 21 helplines. So, if you like, was the slack being taken up by colleagues in the voluntary and third sector? This study suggests to an extent it was. So this showed that calls increased after the kind of COVID-19 outbreak. What's interesting, though, is when they looked at these calls in more detail, they weren't about self-harm or suicidal ideation. There were things like worries about finances or worries about the virus itself. But to an extent, the third sector kind of complementing, taking up some of the work that, some of that reduction in activity may have translated into increased activity in the third sector, but the evidence is quite mixed. So some services, increased, some services didn't see an increase, other services saw an increase in kind of call duration. Actually, is one or two bits of research showing that. But important, I think, in terms of going forward involving voluntary sector colleagues. What's happened since? Well, this is data now, emergency department data on self-harm, produced by Caroline and colleagues. What you can see here is, perhaps, reductions in help seeking around the time of lockdowns. Otherwise, it is a bit up and down, but important to, I think, monitor going forward. And all of this, I think, may change. So, in terms of kind of the economic fallout from all of this, current worries are about, if you like, the cost of living squeeze, fuel prices increasing. They are likely to have impacts on mental health and, by extension, I think, on self-harm. So we must keep an eye on these things. So keeping an eye on things, I think, is really important. But also just remembering the evidence we've got. So, the evidence is still the evidence. The guidelines are still guidelines. The context, though, has changed. So this is, some of the evidence around suicide prevention, but much of it applies to self-harm as well. That actually, we know about all these things being effective. So, thinking about alcohol use within communities, making sure that kids are back at school, financial help for people who are in financial difficulties, all of that was important during the pandemic, will be important afterwards, thinking about kind of media, thinking about the role of services and research. So the evidence is still the evidence. The challenge for all of us, I think, going forward, is how we apply that evidence in the context of the pandemic, and actually now in the context of hopefully recovery from the pandemic, but services still being stretched. So I've talked a little bit about context and the current programme. So hopefully it's given you a good idea of where this work sits, where your plans might sit. Talked a little bit about settings, so plans hopefully addressing different settings that will vary according to your local priorities, but also will address different groups. A bit about the evidence, the importance of assessment, the importance of psychological intervention, but perhaps not relying on things like risk assessment to allocate treatment, and then a little bit about self-harm and COVID-19 and how we move things going forward. And the last thing I always like to do is just acknowledge all the hardworking team back in Manchester, some of whom are obviously on this call, but many others are just kind of beavering away, working as we speak. So I'll stop sharing at that point, and I'll give you a little bit of a breather. We'll take questions, I think, at the end, but I'm hoping you managed to get most of that. What we're going to do now, and I'm pleased to say that we're fairly on time, is I'm going to get Jess and Kira and colleagues to give a bit of an update from West Yorkshire. Very informal, so no kind of pressure or anything. So do just let us know, and then I'll give you kind of 10 minutes just to kind of stretch your legs, hopefully get outside and grab a quick cup of coffee before we reconvene. Is that okay? Jess, can I hand over to you first of all? Is that all right?
If it's all right now, I'll start, and
you'll start.
I'll bring Jess in. So hi everyone. So my name's Keir. I'm the Programme Director for Mental Health, LD and Autism across West Yorkshire. So we thought it'd be easier doing it kind of that way. And I know that we've got a couple of colleagues, at least kind of Kirkley's and potentially Leeds colleagues, to do a little bit of an update about some of the work in our places. So I just thought to set with a bit of kind of context for everyone. So across West Yorkshire, our kind of operating model as a system is based around kind of the primacy of each of our places. So kind of each of our 5 places in West Yorkshire being the most significant unit of stuff. And our West Yorkshire system is the kind of the coordinating bit that tries to help share learning, or to kind of do stuff once where it kind of makes sense to do stuff once. But actually each of our 5 places is the kind of the main unit. So just as a bit of context, so from a point of view of kind of the wider community mental health transformation agenda, so across West Yorkshire we do some coordination and bringing together, and we also do some do want stuff. So a lot of the work that we do is about trying to share some of the good practice that happens in either Leeds, Bradford, Caldervale, Kirkley, and Wakefield, but we are doing some do want stuff around things like, well, what does an outcomes framework look like? What are we doing around things like information governance when we know there's kind of common barriers? How do we create sensible, consistent job descriptions for peer support workers so they're not different in each of our places? And it's similar when we look at the work that Jess leads around our kind of suicide prevention agenda as well. So the real focus that we've had from a suicide prevention point of view is how do we get as much money as we can to our places locally so they can discharge kind of what is needed to support local suicide prevention initiatives. But then some of the do want stuff we've been looking at is things like, well, what does real-time surveillance need to look like? How can that work? How do we focus on some of those potentially underserved communities who impact on each of our places, but maybe there isn't necessarily the volume in a single place to really invest? So things like the Gypsy and Traveller community as well. So that's just a bit of kind of context stuff, really. So I think what is really useful about today is really useful hearing your kind of your earlier presentation. I'm sure it is for kind of clinical and professional colleagues as well, is how do we make sure that we share what's going on in each of our places regarding self-harm from a West Yorkshire point of view, where we can, and that's why it's great to hear from Becky and colleagues from Kirkley as a starter today. And then the question we've kind of got is what is the focus for each of our places and needs to stay there versus what actually potentially could we do once and support as a system more widely? And that might be nothing, or it might be some things, or it might be a lot of things. And that's kind of the journey, I guess, that we're on to the community mental health transformation stuff. So that's kind of my intro and summary, really, other than to say kind of thank you to Jess and other colleagues for getting us to this position where we're able to engage with you guys about the work that you're doing nationally as well. But I hope that makes some sense before I bring Becky in.
No, it does. Really helpful from a kind of conceptual point of view as well, because we're very conscious that a lot within areas there's a lot of kind of different services and fragmentation, and sometimes that coordination function could be coordination and harnessing were the terms that I used yesterday. That might be the thing that really makes this. So Jess, I don't know if you wanted to go next.
Yeah, I suppose just adding to that, from a suicide prevention point of view, I'm the ICS suicide prevention lead, as Kia's mentioned. We've just agreed a new 5-year strategy, and it's brilliant to get your presentation now because so much of the stuff that you mentioned forms an element of that strategy. So some of the key themes are unemployment, primary care, info, evidence sharing, and crisis. So that would be the kind of stuff that we've agreed to look at collaboratively, the do one stuff. So there is the opportunity there to do some more work on this, as you would expect from a suicide prevention strategy. And I think it's just worth saying as well that we've got some brilliant voluntary sector colleagues on the call. So from Battle Scars, and I know Yvonne's here from Norfolk Hall as well. And so wouldn't it be amazing? So they are primarily, my understanding is, peer support organisations who do brilliant work and are not sustainably funded from any statutory source. So wouldn't it be brilliant to get some sort of immediate referral into peer support from primary care colleagues to sort of look at some of that prevention stuff? And so these are the kinds of things that I'm hoping to explore as time goes on. But in terms of a presentation as to what's going on with self-harm in West Yorkshire, I don't think there's one person within our system who's qualified or has the knowledge to do that. So it would be brilliant to hand over to Kirkley's colleagues potentially next, who I know have put something together. And I'm not sure if there's colleagues from Leeds or elsewhere on the call who've done a slide as well. I'm not sure the answer to that question. So that all makes sense.
Yeah, it does. That's really helpful, and particular kind of welcome to. You can't really tell, can you? If we were in person, I'll be looking at Yvonne and waving, and I'm looking at you now on your screen. So particular welcome to you. So Kirkley's, who's here from Kirkley's?
Yes, hi Nav. It's Rebecca at Kirkley.
Hi, Becky. So I was looking around for you on the screen. There you are in the corner. So Rebecca, do you want to tell us about Kirkley's?
Yep, so I'm here with Yvonne from Norfolk Hall. So we're here from Kirkley's. I'm a public health manager at Kirkley's Council, so I oversee the suicide prevention work for Kirkley's. We do have a few slides that I've sent to Debbie, and I wondered whether she'd be able to just pop them up on the screen for me, because Zoom is not my one that I'm familiar with. Thank you so much, Debbie. So we will do this quickly because I'm aware that you wanted to go to break, Nav, but we volunteered to put a few slides together.
That's ever so helpful. Thank you.
So next slide, please, Debbie. So yeah, this is just what we're going to quickly whiz through today. So a bit of a local context. What do we have in place already? What have we done recently on the self-harm agenda? And what would we like some help with? So next slide, please. So we've just lifted this. This is our Kirkley's Suicide and Self-Harm Prevention Action Plan. So for those of you that don't know, Kirkley's covers Huddersfield and Dewsbury areas in the main, and we kind of split them down into North Kirkley's and South Kirkley's because they're very distinct and quite different areas with quite different demographics. So this is our action plan, and these are the 6 high-level work streams that we cover within Kirkley's. So next slide, please. So what I've done is just lift from that action plan some of our bits of information that are most relevant to self-harm. So the main outcome measure that we have is to have a reduction in the rate of intentional self-harm in Kirkley's. And then the 2 bullet points underneath are some of our more specific actions that we've been looking at over the last sort of couple of years. So really wanting to take a preventative approach to self-harm awareness, encourage conversations to reduce myths and stigma around self-harm with all stakeholders that work with young people, and also to promote the self-harm prevention resources that we've recently developed for young people and adults as part of the support package offered by Northorpe Hall. We're really lucky to have Northorpe Hall in our area. I go to Yvonne all the time with questions, and they do fantastic work, but something that I'm really conscious about is that they're very much young people focused, although they do work with parents as well. So I think something that we're wanting to look at going forward is more around our work with adults and self-harm. Next slide, please. So I've just lifted this from our most recent suicide audit, which was covering the years 2016 to 2018 inclusive, so a 3-year period. Particularly looking at the graph on the right, I appreciate it's very small and you might not be able to make it out in here, but basically what this is telling us is that over a quarter of suicides in our area were preceded by self-harm, and half were preceded by a suicide attempt as well. So very much touching on some of the information that you've just gone through in your presentation, Nav, around this being a significant risk factor for suicide. And although there's not a causal relationship there is a relationship of some sort that we need to be able to look at this data and think, right, what can we do to really work with people who are self-harming, because we know that it's a really key opportunity to intervene and prevent further suicides. Next slide, please. So I've just lifted these next 2 slides. You'll be familiar with these from the Public Health England, or OHID, referring to it now, fingertips tool. So this is emergency hospital admissions for intentional self-harm in Kirkley's. So this is, I think, all age. So what this is showing is that there is no significant change in this trend. And if you can see there, it's slightly below the England rate as well. But if we look at the next slide, this is the hospital admissions as a result of self-harm for 10 to 24-year-olds in Kirkley's. And the trend here is showing a trend that's getting worse. So it's really important that we not just look at the rate across all ages, but we look at it in specific age cohorts to be able to determine where the need is greatest. Next slide, please. So I'll just quickly pass over to Yvonne to touch upon some of these bullet points.
So some of the work that we've been doing within Kirkley's is very much about that early intervention and prevention, as Becky said, and raising awareness really, just so that people can start having conversations around self-harm. So we do have some things. Obviously, we are a children's charity, so we have a focus on the child aspect around and young people aspect around self-harm, but also do a lot of work with adults around young people as well to raise that awareness. So we use things like Acute, which is an online counselling service. We do have a single point of contact for anyone who's got a concern in relation to self-harm. This MHST within Kirkley's, which is a mental health in school team, so that's very much about raising awareness around mental health concerns within schools among staff as well, and looking at training around adults around their understanding of self-harm and helpful responses. So as part of the training offer, we do train, we have an introduction to self-harm session that can be for any adults that are working with children and young people, parents and carers that have come across self-harm, and then also for young people themselves. So it does cover quite a broad cohort around self-harm and helpful responses. So those are some things that we've been doing. And next slide, please. Okay, so one of the things that we've been doing is we've done a campaign around Let's Talk About Self-Harm. So there's some resources that have been developed in line with children and young people. There's some guidance for adults and there's some guidance for children and young people themselves. So it's a small leaflet that provides some quick advice and information around self-harm, and we've been running that campaign for about a year now, just to try and get people talking a little bit. Obviously it can be quite a difficult subject, and a subject where there's quite a lot of stigma attached to it, so trying to promote positive conversations around self-harm.
Thanks, Yvonne. Do you want me to carry on, Yvonne, at this point?
Yeah, go on and pass back to you.
Thank you. So in particular, what do we need support with going forward? So I think you've touched upon some of this already, Nav, and your slides will be really helpful for us in this journey. But I think there's something that we need to do about understanding the journey of someone who attends at A&E in Kirkley's with intentional self-harm. And something that Yvonne and I are really keen on looking at is developing an up-to-date self-harm pathway, a really integrated pathway that involves partners with primary care, secondary care, voluntary community sector, that brings in all the resources that we've got locally as well. So that's something on our to-do list that we'd really appreciate support with. We'd like to learn from other areas about community-based support outside of hospital and models of care that are available across the country, not just for children and young people. And we'd really like to strengthen our links to Acute Trust to work with us on this. So learning from the Acute end, you know, who is presenting at A&E, so that we can really use that information to better inform preventative actions in communities. And I think that's the end, Debbie.
Super. That's brilliant, actually, Rebecca and Yvonne. We love a good PowerPoint. So that's great, and thank you for getting those slides. That's really helped us, and will really help me kind of steer the discussion as well. I'm just wondering, just before I release you for a cup of coffee and a quick leg stretch, I'm just wondering if there are other colleagues from West Yorkshire, Leeds. Someone was mentioning Leeds. If you want to kind of raise your hand or get my attention. Oh, there's few, M and Jamie. M and there's two Jamies. This is all getting slightly too much for me on Zoom. M, do you want to start? If you wanted to kind of talk about other areas in West Yorkshire.
Yeah, I'm from Battle Scars, which is a charity that supports people who self-harm. But the kind of special thing about us is that we are peer support, so that literally everybody who is involved in working with the service users has either personal experience of self-harm, which is where I come in, or they are like family or carers of people who self-harm. Like I was sort of hearing some things then that were really interesting. We actually don't aim to stop people self-harming. Our goal is just to support them to try and keep themselves safe, unless like their goal may be to stop, and then we will support them with that, but that's not what Battle Scars is about. Our Battle Scars virtual groups only came about as a result of COVID and lockdown, and we now offer about 10 or 11 groups each fortnight. We have kind of standard groups, then we have groups of people who maybe self-harm less or are just dealing with the thoughts, which are there a little bit more gentle than the standard groups. We also have What's Bothering Me groups, which run without topics. People just get to bring whatever they're struggling with and get support and maybe hear some shared experiences of other people. And we also run social groups as well to try and encourage people to interact within our community.
Yeah, and that's really helpful. It's good. So over the past 20 or 30 years, you know, one of the things, you know, I'm you know, a psychiatrist. I've worked in hospital services. You know, I do ideally, my ideal treatment outcome is for people to stop self-harm. But you know, we're very conscious of what patients and service users tell us about the functions of self-harm for them, and how, you know, in some cases it prevents even worse outcomes for them. But I suppose our, if you like, overarching treatment goal is, you know, self-harm's always a symptom of some kind of distress, and it's about helping people. I think that's the important thing. You know, it's not about getting too I know sometimes, you know, in the past people have got quite cross with me for suggesting we need to kind of, you know, reduce or stop self-harm, but really this program is about helping people. And I think, you know, organizations like yours and others, you know, the emphasis might be slightly different, but we're all kind of focused on the same thing, which is, you know, just trying to help people. And for me, one of the big opportunities here is when people do present to services, to make sure they get a good deal, because too often I think in the past, you know, we haven't done as well as we might in services. So we've really got to kind of pull our socks up, I think, a little bit there. Jamie Pick. Sorry, you're on mute. Yeah.
Yeah, I'm here. Sorry, I'll try and be brief. I'm conscious of the time. I suppose, I'm sure like everywhere, there's all kinds of bits of work happening in Leeds which are related. I don't think we've got an overarching self-harm plan. So the work stems from the suicide prevention plan. But to give a few examples, the personality disorder service in Leeds has shifted its emphasis to working with 18 to 25-year-olds and developing more accessible DPD provision within the community to support that. Our ALP service, which is the hospital liaison service, has been involved with the Fresh Start pilot, the Fresh Start research project, which is about testing out psychological interventions in people who are presented with self-harm. We've recently opened a crisis house in partnership with the third sector organisation, which is a 10-bedded unit which offers a safe space for people to go to. So I suppose there are lots of things that happen that stem from the plan. I suppose my reflection, listening to what you've spoken about, is of the fragmented nature of the system and the organisation. There's loads of good work, and we're really lucky in Leeds with the third sector, with the third sector support and services that are out there. But I couldn't honestly say we've got a really coherent offer for I guess, to support people who presented with self-harm.
Thanks, Jamie. That's fantastic. And I think, you know, one of the things that's becoming very apparent to me, more so in this wave than the earlier wave, is just actually, you know, when people are writing down what they're doing, it's already almost a kind of coherent plan. And part of the function of these meetings seems to be putting people in, you know, in different large areas in touch with each other, because, you know, sometimes people won't have heard of the brilliant work that's going on in their area. So I'll bring Jamie in, and I don't know if Donna, you wanted to come in as well. Donna, did you want to come in? I'll let Jamie in first, and then Donna, and then we'll break for tea. Jamie Scott.
Yeah, I mean, you'd be amazed at the amount of problems we have in every meeting just by simply being called the same phone name. Me and Jamie. But yeah, I'm not going to add too much to that. I was just going to pop something in the chat, actually. It'd be really useful to hear a bit more about some Kirkley's colleagues' experience. I think I'd echo that point from Jamie, really, that what we're probably lacking on is a coherent self-harm level strategy and approach across the city, and hearing what's happening in other place-based areas across the region would be really useful. And equally, we were keen to share some of so we're really trying to focus on where there are gaps. So some of the priorities you mentioned, like younger adults, like transition points, the space between traditional primary and secondary care, part of the transforming community mental health services agenda. We are trying to attend to some of those within Leeds, and so we're piloting at the moment and adapted, as James said, DBT program specifically for young adults at the primary care space with primary care colleagues. So again, be happy to share that across the ICS in terms of some of that shared learning approach, which I think is probably the challenge over the next year or so.
Brilliant. Yeah, no, thanks for that. Donna?
Oh, hi everyone, I'm Donna Hanson. I'm the team manager for the Acute Liaison service in Leeds, and we're the team that are recruiting patients into the Fresh Start programme. So it's people who present in the ED that have self-harmed. The team do our self-harm assessment. We refer them to the recruitment team, which is LYPFT's Research and Development at Leeds University. They then contact the service users for eligibility and suitability, and then they're randomised into one of the therapies, talking therapies, so CBT and psychodynamic therapy. Several of them, it's not a separate service. This is something that my team are doing within our own service. So several of the staff volunteered to do the training, got trained up in CBT and psychodynamic, and they're doing that alongside their own role. We had a pilot in 2020 to 2021 that worked really, really well. It was only for 6 months. So this full programme is running for 18 months, and we've just recruited our first person into the trial. So the team will be delivering follow-up therapy for 12 sessions, with a possibility of 2 booster sessions as well, with the hope that that reduces the self-harm and the presentation in the ED.
Donna, that's really helpful. A real reminder that, you know, I know there's a lot going on in Leeds. I actually worked in your liaison service 3 decades ago.
Right.
So, there you go. So it's nice to hear from you.
Thank you.
I mean, I know in Leeds you've got Fresh Start, you've got Safe Pit as well going, which is trial-based interventions. And for me, you know, that as a researcher and clinician, that's really important. It's the importance of research. But actually, you've got a real opportunity there, which is about using the research to kind of improve the kind of service provision, and then hopefully, when the research works, you know, embedding it within the service. So, yeah, you know, I'm really looking forward to hearing about that. But that's again, you know, we've talked a little bit, you know, colleagues in Leeds saying, oh, it's great that colleagues from Kirkley have presented, but actually, you know, all colleagues in Kirkley and across West Yorkshire might not know about all the research activity that's going on in Leeds. So it's very helpful to know. I'm very conscious we're 10 minutes over. So unless anyone else from West Yorkshire's got anything pressing, I can't see hands. We'll break for 10 minutes. We'll reconvene at 11:30. Holly's then going to present. Holly, Debbie, can we make sure we've got Holly's slides? Because I've just realised, because you'll be a host, you'll need to share them.
Yeah, Sue Gwan's going to share them for me.
That's brilliant. Thank you very much. So it's Holly and colleagues from North East and North Cumbria after the break, and then we'll have a discussion. We never have enough time for discussion, but I'll try and steer it so that we cover a lot of the areas that we've raised. Okay, see you in 10 minutes, everyone. That's brilliant, thank you. That's great. My pleasure to hand over now to Holly Edmondson, who's the Regional Suicide Prevention Lead up in North East and North Cumbria STP. Over to you, Holly.
Hi, thank you. Can you hear me okay? Because I've took my headphones out, they're giving me a sore ear.
No, you hear you perfectly, see your slides brilliantly.
Great, thank you. That's not the first slide. No, it's, thank you. Thanks very much. Yeah, so thank you for the introduction. So I'm the Suicide Prevention Lead for the ICS. So I'll share with you, I'll be as quick as I can because I'm aware we're over in time. It'll just be me giving the presentation, and then at the end, if there's any questions specifically to anything that I talk about, I can hand over to my colleagues if there's something that I can't answer. Thank you. Next slide, please. So one area that we're currently in development with in relation to self-harm is within our real-time surveillance systems and our data collection. So across our region, we currently have 2 ambulance services, NWAS and NIAS. NWAS is a bit more advanced, and they are collating data on self-harm, whereas before we'd just be getting the data on attempted suicide. But now we're really in progress with this, which is really, really valuable to the work that we're doing. We've currently created some developed relationships with NIAS, which is the other ambulance service more in the northeast of our region. And although the system isn't yet in place, we've got some good progress. So we're hoping that will take off very soon. The benefits of this, like I've just said, it's really valuable so that we can identify key themes, any areas for development, any particular groups of patient service users that we might need to focus a bit more work on. And the drawback, really, the main one at the moment, is that it's not consistent across the region. So we can focus on certain parts, but not on others so much with this data. Thank you. Next slide. We currently have some research projects underway that are in collaboration with our network. I won't go into great detail on these, but again, we can take questions. So these are specific suicide and self-harm prevention. That's research on the training that we provide across the region, developing policy and practice guidelines for working with young people in relation to self-harm and suicide attempts, safety planning specific research project, which is taking off really well. We've got some really good progress and there's lots of service user involvement with that one, and a study of the use of safety plans to reduce self-harm and suicide for autistic adults as well. Thank you. Next slide. Thank you. So we continue to drive our training modules right across the region as far as we can. Our training that we bought into has different modules based on who the particular audience will be, but one of our main drives at the moment for this is getting this training to schools and to young people. And so Suzanne, who's also on the call, might be able to give a quick update at the end if we have questions specifically to that. But this project's really promising because we're going to be going into schools, providing some of this training to our young people, and also developing our relationships and engagements with schools on the project and the training that we deliver. Next slide, thank you. So we continue to focus reaching those who don't reach our services, and we know that that's a big gap and it's a big area that we need to focus on. We have drives on our social media pages within our suicide prevention network for the ICS, and we continue to have posts and engagement with our communities through this, which also includes self-harm. Collaboration is a really key focus that we've got, particularly at the moment with our primary care network. So I think it's been touched on before earlier, but I think one of the issues is often capacity within primary care and getting engagement. So we've currently got plans to have some workshops to develop our relationships with primary care, and to also they've actually currently just agreed to take on some of our training, which is really promising, and we hope that that will help them to manage self-harm and mental health in general when they're coming across it, to strengthen the support they get from us as not just the ICS but services altogether, but more importantly the care that the patient and the service user receives from them, particularly relating to self-harm and suicide prevention. Within the Northeast particularly, there's some really good grassroots projects and charity organisations focused on more creative digital. I think you've mentioned it before, the creative digital element of intervention and how we can reach people in a different way. So there's quite a lot of projects in the Northeast that are focused on that specifically. We did notice that there's a gap. There's definitely a gap in terms of specific self-harm projects and organisations, which we hope over time will develop. There's lots and lots on suicide prevention, but definitely a gap in self-harm. Next slide, please. Thank you. This is just a brief example of a creative tool really that's used specifically in Cumbria. So these are self-harm kits that are distributed to services, primary care, schools, anybody that requests them, where there's guidance on self-harm. There's some, like I think you can see there's advice on how to keep self-harm wounds clean and using other alternative techniques that might be helpful. It's been a really, really well welcomed project in Cumbria. Next slide, please. And these are our resource tins. I know we've talked about these quite a lot over the past year, so some of you might already be familiar with them, but these are aimed at suicide and self-harm. So these resource tins we have distributed right across the region. We have them in lots and lots of different organisations and services, particularly GPs again, pharmacies, schools. Anyone that requests them can have them, and within that tin is self-help tools, resources, information on how to access support. And the idea, really the fundamental idea behind this, is that people that don't feel confident enough to be able to come out and say, I'm struggling, I need some help, can just pick something out of the tin that they would need for resource and support. Next slide, please. And right, so further plans. So what we're currently developing all the stuff that I've already talked about and the current work. Within this year, we want to have a campaign specifically focused on self-harm. So that's within our suicide prevention network, and will reach the whole of the region. And also to develop some self-harm community workshops where we just try and improve engagement from various different sector organisations, service users themselves, and anyone that we can get involved, really. Some future needs and areas that we really think we probably need more focus or support on is more creative ideas on reaching communities, so particularly those that don't access services. I still feel like, as some of you have mentioned earlier, it's still a really significant gap, and we'd like to learn from each other. Again, like it's already been mentioned, so what are other areas, what are the other regions doing? Is there any specific projects that are out there that we could learn from? And a bigger drive on self-harm separate to suicide. So I think I actually hadn't thought about this before, and it might have already been mentioned in some of the national workshops, but was a manager who had experience as a service user herself, and she said that it can be a barrier to accessing services when the services might be specifically targeting self-harm and suicide together. And she recognised that although there's a definite link, and that there's an absolute crucial element for services to focus on self-harm and suicide together, like we've talked about, the risk indicators and the data we know, but there definitely seems to be a need for specific self-harm, like this project we're talking about today, but more and more, if we can, to keep self-harm not separate, maybe that's the wrong word, but to have specific self-harm interventions more increasing. That's me. I've given a really quick snapshot because I'm conscious we were over time and there might be questions for you at the end.
Brilliant. Okay, that's fantastic. Great. We'll stop sharing. That was really fantastic, Holly. I think one there's just a few things I can draw out from it. I think that helpful also from the previous presentations as well. I mean, one is the importance of settings. So we've talked about primary care. Engagement with primary care is obviously a hot topic. How we best do that. A lot of areas are struggling with that. If it's just some kind of digital offer, do GPs and other primary care professionals engage? If it's a face-to-face, will they actually let you into the practice? How can we engage primary care professionals? But my examples of settings was just an example. So I really like the fact that you were tailoring it to your setting. So Northwest Ambulance and ambulance services in other areas, they're talking about community pharmacy. So our settings are just an example. Again, what came out in your research was, the synergies between service provision and research. Lots of research going on in Leeds. Clearly, lots of good work going on with you guys. But I think it's a two-way thing. So the fact that research is going on, it increases the profile of self-harm services and hopefully kind of feeds into service provision. The awareness thing's really interesting. It's been mentioned a couple of times, and obviously, we mustn't stigmatize self-harm. But I think if we're talking about awareness campaigns, one of our bits of advice is the evidence around awareness raising actually isn't that strong. It's a thing we all think is a good idea, and our steer to areas really is if you're having some kind of awareness raising public health type campaign, being very clear on what the intended outcome from that is. So is it perhaps to raise awareness and steer people towards services? I mean, certainly kind of anecdotally what's worked, and this is from the suicide prevention program, is what works is something that's kind of awareness raising with something to back it up, like a service or a helpline or some resources to kind of back it up, rather than just awareness raising on its own. So thinking, I think both areas have talked about awareness raising, thinking very carefully about what the purpose of that is. Holly, really interested to hear about the self-harm kits and also the resource tins, which I have seen before. I think the message there is if there's any way you can formally evaluate those, it would be fantastic. The simplest thing is just to ask people, obviously, what they thought of the tins, but going back to them, how they use them. Ideally, you can be thinking about, did it make a difference in the people who got them versus not? That may be a bit beyond, but they look so good. you know, I can imagine, you know, service users really like them. But if you can get some data, some information, I think that would help other areas if they're thinking about something similar. And the last point I think you raised, Holly, that's really important is about prioritization of self-harm. Originally in the suicide prevention strategy, it was just kind of embedded within the kind of high risk groups. What we've done subsequently is try and draw that out. So it's got its own place in the suicide prevention strategy. It's very helpful, I think, when we start, you know, and certainly some colleagues have found it helpful to draw on, you know, the existing infrastructure in place for suicide prevention. But you're absolutely right. In some senses, to give it the priority it needs to come out of the shadows. And, you know, Donna and others all know, you know, self-harm is an important problem in its own right. So I think, you know, that I think would be absolutely fantastic. And it's one of the reasons this program is focusing on community services for self-harm rather than, you know, community services for suicide prevention, which are covered by other things, but synergies between the programs. Just very quickly, just responding to some of Kirkley's colleagues' kind of points about, you know, where they want to go. I mean, one of the points was about, you know, understanding your ED, your emergency department pathways locally and across the different services in your patch. That's really important. Another aspect was working more closely with acute care colleagues, and I think that's crucial. If you like, the key personnel, the key link people there, I think for me would be liaison psychiatry colleagues. If you know, involve them locally. You know, I know some of them are on the call, so they are, but involve them locally to try and, you know, get into both the ED pathways and the liaison psych stuff. The models of care for people in the community, I think, is a real challenge. A lot of areas are grappling with that. Some areas through kind of education, through higher education, in other areas through primary care. And I don't think there's one kind of fixed model. But again, linking in with perhaps kind of public health, mental health promotion type colleagues might help with that. Okay, I'm going to open it up now for kind of wider discussion. You can ask us anything, ask each other anything. We've got about 15 minutes. So anyone want to kind of raise anything, discuss anything? I've obviously frightened you all with my kind of timekeeping, but we do have some time for kind of questions now. So
Can I make a comment?
yeah.
It's just in regards to, you know, I think a lot of people have mentioned sort of the collecting of data on self-harm. And I also noticed that in a couple of the presentations, people seem to be making a distinction between self-harm and suicide attempt. I mean, we don't tend to do that in our research, but I think, you know, in relation to collecting data, you need to have a very, very clear definition of what it is you're collecting and what types of harm you are collecting to be able to, you know, to quantify it, basically. So, I mean, I would recommend including suicide attempt in self-harm, but, you know, it depends on your decisions and, you know, the exact group of people you want to target, but it is, you know, self-harm means different things to different people, so it is worthwhile being very, very clear about what it is you're actually going to collect and what groups it is you're collecting information on.
That's really helpful, Caroline. And I suppose, you know, our steer would be you want data on, you know, all people who hurt themselves. I mean, you know, for local needs, if you're wanting to kind of split that may be okay. I mean, the research evidence around that is, you know, not that maybe you treat them as one group because everyone's at high risk of outcomes, but it depends on local needs. Of course, we realise that, but also I think, you know, some of the challenges around data collection are you know, very are very evident. I'm just wondering, I mean, there's a couple of things that I could pick up on Holly's presentation. I mean, Holly, do you have a similar, you know, if you like, various mental health services within your patch? Are you grappling with similar issues to West Yorkshire?
Could you just clarify that question?
Yeah, so have you got several, if you like, mental health service providers in your patch who you would need to link with in terms of, what you're doing for self-harm, or is it more unified?
Absolutely. I think because the North East and North Cumbria is such a wide patch, we've got no option but to link as many people in as we can. And so within our suicide prevention network for the ICS, we have a core group, and we ensure that all key partners from each different locality are involved with that. But in addition, we would have separate branches with our mental health trust and linking in and particularly working together. But it's something that we've developed really well. Does that answer your question?
Yeah. So I suppose what's the big kind of take home for areas which, would you say you've got good kind of coverage and buy-in then?
We've definitely got good coverage and buy-in. I think the issue that we've got is consistency, because there's just so many different, and I think for us, the Northeast is definitely richer in different services. It's Newcastle areas are quite big cities. In Cumbria, we've got quite a lot of rural areas, not as much access to specific services, which happens in all regions, I know that, but keeping consistency based on area need and what we need to develop is quite a challenge. People working together is definitely one of our strengths.
Brilliant. Okay, thanks, Holly. That's helpful. Jamie Scott.
Hi. Just as we've got some time, I'm just curious about this question around your presentation around the risk management and assessment comment. I'm only raising it because we're having lots of debates, well, ongoing debate, but currently debate within the organisation, within our trust around, I guess, the value and merits of structured risk management and assessment tools such as FACE and other, other kind of frameworks. What would your position, would your take-home message, your proposal be that they, in a nutshell, aren't worth the investment and a resource that goes into completing them, or is it more of a kind of nuanced point? My view would be that I think if the primary task of those assessments and risk management is coming to a score, which then directs treatment, then they have limited validity. But as a framework for collecting information and organising your thoughts in terms of somebody's risk presentation, then they can be purposeful. And sometimes it becomes particularly problematic when the purpose of them becomes what score you get at the end. And then almost regardless of clinical judgment or assessment of the person, that becomes what dictates the response.
Yeah.
But it was quite a stark position, which I'm interested in. Actually ditch them.
Yeah, we've talked a lot about this over the years, and certainly when we present, we tend to present it in quite stark terms. But I'm also very aware of the kind of clinical realities here. The NICE position is pretty clear. If you look in the 2011 guidance, it said don't use tools to determine management. Don't use tools to predict who is and isn't going to get treatment. Now, what you're saying is, well, the tools have a wider purpose, which is kind of information gathering, kind of assessment. It's a means of recording an assessment rather than necessarily a score. And I think you're absolutely right. So, I'm not saying don't do risk assessment, because actually we all do kind of risk assessment. We have to individualize our management plans, but the focus should be away from risks and prediction and much more about clinical needs and modifiable factors. So it's about changing that purpose. And the danger with having structured risk assessments that give you a score is that inevitably busy clinical staff default almost to treating the score and are given false reassurance when the score is low, etc. And so far from assessment tools can't do any harm, can they, Nav, is one of the things that sometimes comes up. They can when they detract from the primary business of what we're all up to, which is actually to do a proper assessment that feeds into a management plan that's going to have the service user. So our steer is really to move away from, if you like, structured risk assessment tools or maybe it's what you call them. Maybe if you call it, you know, an assessment or an assessment tool, that might be okay. But this idea that, you know, there is some predictive value to these is a bit of a nonsense. Yes, you know, you've got lists of, you know, generic risk factors, generic risks, but predicting which individual will then go on to have, you know, repeat self-harm or even, you know, sadly die by suicide is nigh on impossible. So I think it's fine if the purpose of it is to collect the information you need. It's fine if the you know, purpose of it is to make sure staff are collecting things in a consistent way, but it isn't fine if staff end up treating the score, or if the process of the risk assessment actually detracts from the process of, you know, what we should be doing, which is the kind of clinical assessment. So I mean, we've written lots on that, and if Debbie, I mean, if you could dig out some of the, you know, maybe the risk assessment report, the risk assessment paper, maybe ask Leah for one or two of her key papers, and we can send some stuff to Jamie without overwhelming him with the 200 publications that we've done on this, but maybe some of the key ones that might help you. But it is quite a nuanced thing, because one of the things we always get from staff is, well, if you're saying don't do risk assessment tools, what we're going to use then? How can we show we've done the assessments? But it's about showing that we've done good quality assessments rather than showing we've, you know, ranked the scores.
Or simply, but I guess perhaps retain some of the assessment and risk management, but remove or avoid the scoring element of it.
Yeah, I mean, you know, that's one of the things,
you know, de facto default, then it generates its own logic and energy, doesn't it?
I'd really steer away from scores. I'd steer away from RAG ratings, red, amber, green. You know, if you're automatically directing people to management in an algorithm-based way, I think that's bad news. So I would urge you to not do that, and that would actually be contrary to national guidance as well.
Yeah, that's really helpful. Thank you.
Okay. Great. I mean, I just wanted to say something about data as well. It was something that I think Rebecca and Yvonne presented self-harm admissions data, and that's okay. The only problem with it is, of course, we know not all people who self-harm end up at a hospital, but actually not all people who come to a hospital end up getting an admission that then gets into HES, that then gets into the fingertips tool. So that's worth knowing about. But self-harm is really difficult to record. So one of the things I think you rightly said is you're doing this in order to kind of think about kind of trends up and down. So one of the important things is sometimes data collection isn't complete, but actually if it's consistent, it can help you. So I'd you know, urge you to do that rather than, you know, spend lots and lots of time and effort, you know, trying to set up a self-harm monitoring system. And that would be great, and we've got a self-harm monitoring system in Manchester and elsewhere, but it takes an awful lot of work, and it may be that there are other ways you can record outcome data, and, you know, we're encouraging areas to maybe focus their activity in terms of evidence-based interventions rather than necessarily the monitoring. But also I think you know, measuring what we do is important. Right, okay. Lots of activity in the chat, which is good. Anyone want to raise anything either from my presentation or the other presentations at all? No? Okay, well, you've got us here, you sure? Okay. I think, you know, the other bit of this is this isn't the end of you hearing from us. So Debbie will be in touch with emails, but what happens quite often is, you know, you'll come up with something that you want a bit of help or advice on. So do feel free to email us. Caroline and Leah will be in touch with the so-called kind of interactive clinics, where it's not just 2 areas, it will be all the areas involved in the programme will be invited. We'll bring kind of specific issues. Sometimes we'll have someone from our expert reference group giving a little bit of a kind of, you know, giving a view or raising an issue. Sometimes we'll have issues raised by individual areas. So that will be part of what happens going forward. And also, you know, as you develop your plans, we'd be delighted to hear from you and delighted to you know, look at those really. If you wanted advice with them. Fantastic. Caroline, anything you wanted to add at all?
No, nothing from me.
That's great.
Thank you all for coming.
That's brilliant. Debbie, anything from your point of view?
No, I'll send some papers to the people that have asked for them.
That's fine. That's brilliant. Ian, everything? Do we need anything else? Have I forgotten anything?
I think you've covered everything quite well there, Nav, and quite clearly as well.
Oh, you sound surprised, Ian, but that's okay.
I always sound surprised. No.
Sugwan?
No, nothing extra to add from me.
That's brilliant. Well, thank you all very much for coming. Stay in touch, and I mean, one of the things that's fantastic is just hearing from you all and hearing about all the excellent work that's going on. It's very kind of energizing and enthusing for all of us here, and for me in particular. So thanks for all your work, and see you next time.
Thanks, bye.
Thank you.
Thank you.